Hey everyone, my name is Michael Doyle, one of the EMS fellows at Albany Med. And today I have a quick overview here of the new medication on formulary, Olanzapine, which is classically known as Zyprexa being the brand name. This is one part of kind of a two-part series we're doing. This is kind of a brief overview of the basics of the medication, and myself and my co-fellow Dr. AJ Halstein go into a little bit more detail on a following podcast, so please check that out as well. So let's jump on in. Okay, so olanzapine is replacing haloperidol, also called Haldol, on the formulary, particularly for patients with agitation. The reasons for this is kind of multifold. Generally, haloperidol is going to have more side effects, so olanzapine is a little bit of a safer medication. Olanzapine is very well tolerated, and really it's almost exclusively olanzapine has replaced haloperidol in the emergency department. And so physicians have very good experience and are very comfortable with it, and it's used much more commonly in the hospital setting. So when you're calling for medical control, the doctors are going to be much more likely to understand the effects of this medication. We can find olanzapine on a few different protocols. Primarily, we're going to see it under the behavioral agitated patient section. This is going to be for both adults and adolescents. It also makes an appearance under the hospice care, which would generally be a consideration for patients with refractory nausea or vomiting. Here under the agitated patient section, it's way at the bottom on the second page. It's going to be under medical control options. So if we take a look and zoom in a little bit on this blurry image here, we're going to get more of the details. And so as you can see under medical control, you can call and request this medication, olanzapine. It's administered 10 milligrams IM one time. There's also a sublingual formulation, which we'll talk about. It can be given in conjunction with midazolam, but of course the synergistic action may predispose to a little bit more sedation than we would desire. We classify olanzapine as an atypical antipsychotic, sometimes called a second generation or newer generation antipsychotic. The typical or first generation antipsychotics include haloperidol, medications like thorazine and droperidol. The mechanism of action in olanzapine on how it works exactly is not totally understood, but it does have activity at multiple different receptors, primarily dopamine and serotonin receptors, with also some less effects on alpha-1 adrenergic receptors and histamine receptors. Primarily the reason that, or the mechanism that we're after is the dopamine and serotonin antagonism action. That's primarily what's going to cause the effects that we're looking for in an acutely agitated patient, and especially in patients that have underlying psychotic disorders. So when do doctors typically use this? It is oral medication that patients can take regularly, particularly patients that have bipolar disorder, that have manic features. It's also used in agitated patients with schizophrenia or bipolar disorder to help with the agitation. It can be used to supplement treatment-resistant depression to kind of augment other agents. And it's also just used typically or in maintenance therapy for schizophrenia. This just might be one of the primary medications that a psychiatrist may use to treat schizophrenia long term. Okay, so in the pre-hospital setting, in the emergency department setting, this is, of course, primarily going to be used for patients that have acute agitation, that have failed verbal de-escalation or may not be amenable to any verbal de-escalation techniques that you think are going to need emergent evaluation in the emergency department. So if this is something that you feel the patient would benefit from, it is a medical control option, so please give a phone call and discuss the case with your local medical control doctor. Why would you call medical control over giving something that's on standing orders, such as midazolam? We see that typically olanzapine can be a little bit more effective in patients that have an underlying or some sort of baseline psychiatric disorder, such as schizophrenia, especially if there's a component of the disorder of delirium or psychotic features. Olanzapine can work much better than Versed or midazolam, so that's something to consider. When you do give a call, the dosage options principally start at 10 milligrams intramuscular. That, of course, can be lowered. 5 milligrams is not an uncommon intramuscular dose, and of course that can always be repeated if needed. And it can be combined with midazolam. So if you are giving or have already administered midazolam, please let medical control know, but it's absolutely something that can be combined and actually is frequently combined intentionally in the emergency department. So just keep that in mind. There is an oral formulation. So I mentioned earlier, there's a sublingual formulation that is occasionally used in the emergency department. These are good for patients that are may be amenable to taking an oral tablet or an oral pill to avoid an intramuscular injection. So this is a consideration as well. However, it is not a required medication to carry. Okay, so how do we actually administer this medication? Well, it comes in a powdered pellet formulation that needs to be reconstituted with 2 milliliters of saline or stellar water. Typically, it's like a little bit of a yellowish color or yellowish hue to it. At that point, you'd have a concentration of 5 milligrams per 1 milliliter. So it's easy. If you're going to give 5 milligrams, it's 1 milliliter. And if you're going to give 10 milligrams, it's going to be 2 milliliters. And as I mentioned earlier, this is going to be an intramuscular medication only, please. This medication occasionally will be given IV in the emergency department, but in the pre-hospital setting here, we're going to be limited to intramuscular use. So just keep that in mind when you're going to reach out to medical control. That really should be an IM injection only. As we discussed, there's very few side effects. The first one listed here, dystonia. That's very rare and happens very infrequently. If that is a concern afterwards, I would give medical control a call because there are some options to treat it, such as a dose of Benadryl or a dose of benzodiazepine. Sedation is our goal. That's what we're trying to accomplish. Patients generally get a little bit sleepy, tired afterwards. The concern of hypoventilation or bradypnea is rare. It's most common if you're going to be giving higher doses or in combination with other types of medication, but it is not primarily going to cause hypoventilation in a majority of your patients. But of course, after you have ensured your safety, the patients have to be on extensive monitoring. So that's going to include cardiac monitoring, end-tidal, and SpO2. And you're going to watch their respiratory rate closely. Okay, thank you everybody for listening. That about does it today. I hope this was brief and educational for you all. If you have any questions, please don't hesitate to reach out to any of us. We're happy to take those. And like I said, there's going to be a following podcast on the REMO YouTube page with a little bit more details on the medication and a little bit of a case study. We're trialing this new format, so please give us feedback on that as well and let us know what you think of the podcast format. Okay, hope everyone has a good night.